You know that feeling when your heart, like, skips a beat with excitement?
Mm-hmm.
Well, imagine your heart feeling, well, stretched, almost like it's working way harder than it should, even when you're just chilling out.
Right.
That's kind of the world we're diving into today. Dilated cardiomyopathy, or DCM. You asked us to explore this condition, so let's get right into it and unpack what's really going on.
Exactly. Dilated cardiomyopathy, DCM. It's actually the most common type of cardiomyopathy.
Okay.
And cardiomyopathies are basically diseases of the heart muscle itself. So think about the heart's main pumping chambers, the ventricles.
Yeah.
In DCM, these chambers get bigger, enlarged, and sometimes their walls thin out a little bit, kind of like a balloon that's been blown up too much.
Okay.
And the really crucial thing is that the heart muscle gets weaker. It just loses its ability to squeeze properly, to pump blood effectively out to the body.
So it's pretty serious then.
Oh, absolutely. It's a significant condition. And diagnosing it often means we first have to rule out other common heart issues, like, blocked arteries from ischemic heart disease or problems caused by high blood pressure.
Right.
So DCM fits into this broader group of 5 main cardiomyopathy types. There's hypertrophic, dilated, which is our focus, arrhythmogenic, restrictive, and then a sort of unclassified category.
Gotcha.
And our mission today, really, is to pull out the essential knowledge about DCM from the sources we've looked at, make it clear, concise, and hopefully memorable for you.
Perfect. Okay, so what actually starts this whole process, this weakening and stretching of the heart muscle? You mentioned sometimes we just don't know.
That's right. Yeah, what we call idiopathic DCM, where the cause is unknown, is actually really common. But we do know that family history can be a huge factor.
Okay.
So, for example, certain genetic conditions like Duchenne muscular dystrophy are known to be linked with DCM.
Right.
And if you look at the numbers, genetics seem to be involved in about 35% of all DCM cases.
Wow, that's quite high.
It is. We're talking about specific mutations in like 60 different genes identified so far. And often, these are passed down in families in what's called an autosomal dominant pattern.
Meaning
You only need one copy of that altered gene from one parent to potentially develop the condition.
I see.
Which really underlines why, genetic testing is becoming more and more important, not just for the person diagnosed, but also for potentially identifying family members who might be at risk and could benefit from screening.
Yeah, that makes a lot of sense. So, okay, genetics is a big piece for maybe a third of people. What else can trigger DCM?
Well, infections can definitely play a role. Certain viruses, things like HIV and enteroviruses, have been linked to developing DCM later on.
Okay.
Then you've got lifestyle and environmental factors, things like drinking too much alcohol over a long period or using recreational drugs like cocaine, heroin, even amphetamines.
Yeah.
They could directly damage the heart muscle.
Right. Toxic effects.
Exactly. And even some necessary medical treatments, unfortunately. Certain chemotherapy drugs, like doxorubicin is a well-known one, can sometimes cause DCM as a side effect.
Gosh. It's a reminder, isn't it, how interconnected everything is.
It really is. Your lifestyle, your medical history, it can all impact heart health in ways we might not expect.
So it's not just genes or outside toxins. Are there other health conditions that might sort of pave the way for DCM?
Absolutely. We see links with certain autoimmune conditions.
Like what?
Well, conditions where the body's immune system attacks its own tissues. So things like thyroid disorders, SLE, that's lupus and rheumatoid arthritis, can sometimes be associated with DCM.
Interesting.
Also, metabolic problems, especially poorly controlled diabetes, seem to increase the risk. And sometimes pre-existing heart conditions, like if someone's had high blood pressure for a long time or ischemic heart disease, those can eventually progress and lead to a dilated, weakened heart.
Okay.
Oh, and we also need to mention infiltrative causes. That's where substances that shouldn't be there build up in the heart muscle.
Right. Like what kind of substances?
Things like iron overload in haemochromatosis or inflammatory cells in sarcoidosis or abnormal proteins in amyloidosis. So yeah, it's a really diverse range of potential causes.
It really is. So the why can be complex, but let's talk about the what. What's actually like physically happening in the heart when DCM develops? The pathophysiology.
Yeah, so the core problem is that dilation, the enlargement, and often a bit of thinning of the walls of the ventricles.
Okay.
You can almost imagine stretching a rubber band over and over again. Eventually, it loses its snap, its elasticity.
Right.
It's similar with the heart muscle here. It loses its ability to contract forcefully. We call this systolic dysfunction.
Systolic meaning the squeezing phase.
Exactly, the squeezing phase. The heart just can't pump enough blood out to the body with each beat.
And what does that lead to?
Well, because it's not emptying properly, pressure can start to build up inside the heart chambers as they try to fill with the next load of blood.
Ah, like a backlog.
Kind of, yeah. And over time, this increased pressure and the extra work the heart is trying to do puts a huge strain on it. And that's what can eventually lead to heart failure.
Okay, that makes sense. So if someone comes in with symptoms that might suggest DCM, what else are doctors thinking about? What needs to be ruled out? The differential diagnosis.
That's a really crucial step in the process. The main things we need to distinguish it from are significant valvular heart disease problems with the heart valves themselves, and of course the other types of cardiomyopathy.
Right, those other 4 types you mentioned earlier.
Exactly. So we need to make sure it's not hypertrophic cardiomyopathy, that's where the muscle gets too thick,
Okay.
or restrictive cardiomyopathy where the muscle gets stiff and can't relax properly, or ischemic cardiomyopathy, which is caused by poor blood flow from coronary artery disease, or arrhythmogenic right ventricular cardiomyopathy, which mainly affects the right side of the heart. Getting the diagnosis right is key, obviously.
Absolutely. So how common is DCM? You said it's the most common type, especially here in the UK. Do we have any numbers?
Yeah, the estimates suggest a prevalence of around 1 in 2,500 people in the UK.
Okay, so not super rare, but not every day either.
No, exactly. And like we said, that genetic component is significant around 35% of cases, linked to those 60 or so genes.
Right.
Age-wise, it's most often diagnosed in adults, typically between 20 and 60 years old. But it's important to remember it can affect children too.
Okay. Any differences between groups?
It does tend to be diagnosed more often in males than females. And there's some evidence suggesting certain genetic variants might be more frequent in people of African-American descent.
Interesting. Okay, so what might someone actually notice? What are the sort of telltale signs or symptoms if DCM is developing?
Well, often the very first symptoms can be quite subtle, maybe even a bit vague. Things like just feeling tired all the time, unexplained fatigue, or a general sense of weakness.
Things you might put down to something else initially.
Exactly. But as the condition progresses, then we tend to see the more classic signs of what we call congestive heart failure.
Okay, like what?
So a doctor might notice a raised JVP, that's the jugular venous pressure in the neck veins.
Right.
Edema is common swelling, usually starting in the legs and ankles. And pulmonary congestion, which is fluid building up in the lungs, causing shortness of breath.
That sounds more serious.
It is. So other key symptoms people might report are significant shortness of breath, maybe just walking across the room or even when lying down. Swelling can also happen in the abdomen, sometimes chest pain or discomfort, episodes of feeling faint or lightheaded.
Okay.
And in more severe situations, people might become aware of a rapid or irregular heartbeat. Atrial fibrillation is quite common in DCM. Or, tragically, the first sign could even be a sudden cardiac arrest.
Wow. Okay. And what about when a doctor examines someone? What might they hear or feel?
Well, listening to the heart with a stethoscope, we might hear a systolic murmur.
Yeah.
It's an extra sound during the heartbeat, often caused by the mitral or tricuspid valves leaking slightly because the heart chambers have stretched them out of shape.
Yeah.
That's called regurgitation.
Right.
We might also hear extra heart sounds, specifically what are called S3 or S4 sounds.
Yeah.
These can indicate increased pressure inside the ventricles or maybe some stiffness.
Okay.
And a really key finding, often seen on a chest x-ray, is that the heart looks significantly enlarged. Sometimes it's described as having a balloon appearance.
A balloon shape. Okay. So based on all these clues, symptoms, exam, maybe the x-ray, what investigations really nail the diagnosis and show the extent of the problem?
The absolute cornerstone for diagnosing DCM is usually an echocardiogram.
The heart ultrasound.
Exactly. It's fantastic because it lets us see the heart's structure and watch it pumping in real time. We can measure the ejection fraction that tells us how well the heart is squeezing blood out.
Right, the percentage pumped out.
Precisely. And the echo clearly shows if the chambers are dilated, how much the systolic function, the squeeze, is reduced. If there's diastolic dysfunction, problems relaxing, and if the valves look okay.
Okay, so echo is key. What else?
An ECG, the electrocardiogram, is essential too. It checks the heart's electrical activity.
Looking for arrhythmias?
Yeah, looking for arrhythmias like atrial fibrillation, any problems with the heart's conduction system, maybe a fast heart rate called sinus tachycardia, or delays in the signals like a left bundle branch block. Sometimes we just see nonspecific changes in the ST segments or T waves.
Okay.
For even more detail, especially on structure and function, We might use advanced imaging like a cardiac MRI or sometimes a CT scan. These can give really precise measurements of the dilation and show if there's any scarring in the heart muscle.
And blood tests.
Blood tests are definitely important, particularly measuring a hormone called B-type natriuretic peptide, or BNP.
Oh.
Yeah. Its levels tend to go up when the heart is under strain, like in heart failure. So it helps with the diagnosis, but also with monitoring how someone's doing and giving an idea about their prognosis.
Useful marker, then.
Very useful. And then, depending on the whole picture, we might need to do some more digging to figure out that underlying cause we talked about earlier.
Right, those additional investigations, what might they involve?
Well, a chest X-ray, as we mentioned, confirms the heart size and checks for fluid on the lungs, pulmonary edema.
Okay.
Sometimes a cardiac catheterization is done. That involves putting thin tubes into the heart to directly measure the pressures inside the chambers.
Right.
And usually, as part of that, or separately, a coronary angiogram is performed. That's where they inject dye to look at the heart's own arteries, the coronary arteries. In classic DCM, these are typically clear, no major blockages. That helps rule out ischemic cardiomyopathy.
Gotcha. So you're ruling out blockages as the cause.
Exactly. And then, in very specific situations, we might consider an endomyocardial biopsy.
Taking a tiny piece of the heart muscle.
Yes, a very small sample. It's not done routinely, but it can be really helpful if we strongly suspect an infiltrative cause, like amyloidosis or sarcoidosis, or perhaps inflammation like myocarditis.
Okay, reserved for specific cases. So once you have the diagnosis confirmed, what's the plan? How is DCM managed?
Right, management really has several main goals. We want to relieve the symptoms, try to improve the heart's actual function, and crucially, prevent complications down the line.
And how do you do that? Medications.
Medications are absolutely central. Diuretics like loop diuretics, furosemide or thiazide diuretics, are used to get rid of excess fluid, reduce that swelling and breathlessness.
Makes sense.
Then drugs like ACE inhibitors or ARBs are really important. They help relax blood vessels, reduce the workload on the heart, and can actually improve its function over time.
Okay.
Beta blockers are another key group. They slow the heart rate a bit, reduce strain, and have been proven to help people live longer and feel better. Digoxin is used less often now, but might be helpful in some cases, especially if someone also has atrial fibrillation. Spironolactone or similar drugs can also improve survival in heart failure.
Okay, quite a few different types there.
Yes, and sometimes nitrates might be used, particularly if there's difficulty with the heart-relaxing diastolic dysfunction or ongoing lung congestion. And importantly, if someone has AF or artificial heart valves, or we know they have a clot in the heart, they'll need anticoagulation blood thinners to prevent strokes.
Wow, okay. So a potentially complex medication regime. What about non-drug approaches?
Lifestyle changes are vital too. Reducing or ideally cutting out alcohol is often recommended, especially if that was a contributing factor. And managing any other underlying conditions really well, like keeping blood pressure and blood sugar under tight control if you have hypertension or diabetes.
Right, tackling the whole picture. Are there more sort of interventional treatments, laces or surgery?
Yes, definitely. For people who are at high risk of dangerous heart rhythms causing a cardiac arrest, we might implant an ICD, an implantable cardioverter defibrillator.
Like an internal emergency device.
Exactly. It monitors the heart rhythm and can deliver a shock if needed. Then there's CRT, cardiac resynchronization therapy. This involves a special type of pacemaker that helps the ventricles beat more in sync, which can improve symptoms and heart function in certain patients.
Okay.
If there's severe leakage from the mitral valve, that mitral regurgitation we mentioned sometimes, surgery to repair or replace the valve might be considered, like a mitral annuloplasty or valve replacement.
Right.
And for tricky recurrent ventricular tachycardia, that's a fast, dangerous rhythm from the ventricles, a procedure called catheter ablation might be an option to try and stop it.
And the ultimate option.
For patients with very severe DCM who aren't getting better despite all the medical therapy, especially if they're younger or have familial DCM, heart transplantation can be a life-saving treatment. The outcomes, particularly for familial cases, can actually be excellent.
That's incredible. Any research on the horizon?
There is ongoing research, yeah. Stem cell therapy is one area being explored, with the hope it might help improve the left ventricle's function and maybe even reduce the size of the dilated chamber. But that's still more experimental at the moment.
Okay.
So overall, the management approach is really tailored to the individual. Their specific situation, their age, how they respond to treatments. But the core principles are very much aligned with standard heart failure management.
Makes sense. So thinking long term, what's the outlook, the prognosis for someone with DCM? And can anything be done to prevent it in the first place?
Well, the prognosis really varies, and it's quite closely linked to how severe the disease is when it's first diagnosed.
Huh?
Things like sticking carefully to fluid and salt restrictions, being really compliant with medications, and doing appropriate doctor-approved exercise can definitely make a positive difference.
Right.
Looking at broad statistics, the approximate 5-year survival rate is often quoted as being around 50%.
Okay, so still quite serious.
It is serious, yes. And certain things might suggest a tougher prognosis, like if there's significant mitral valve leakage or problems with the heart-relaxing diastolic dysfunction. And a specific type called peripartum cardiomyopathy, which occurs around pregnancy, unfortunately carries high risks. And we always have to remember that risk of sudden cardiac death from arrhythmias is a major concern.
Which is why those ICDs are used sometimes.
Precisely. Getting an accurate genetic diagnosis, if possible, is also becoming more helpful for predicting the likely course and tailoring care. And as we said, for those with advanced refractory disease, heart transplantation remains the key option.
And prevention, apart from managing risk factors like alcohol.
Yeah, avoiding excessive alcohol and drugs like cocaine is definitely a preventative step. Beyond that, it's really about early diagnosis and good management of any potential underlying causes, controlling high blood pressure, diabetes, treating infections promptly, that sort of thing.
Right. Proactive health management. And finally, what are the main complications people with DCM might face?
The big ones really stem from the heart not working well. So progressive worsening of heart failure is key.
Okay.
Developing conduction problems leading to arrhythmias, we've mentioned atrial fibrillation, and the dangerous ventricular tachycardia. Because the blood flow inside the enlarged heart can be sluggish, there's a risk of blood clots forming, which can break off and travel, potentially causing a stroke.
Right.
And then, as we stressed, that significant risk of sudden cardiac death or cardiac arrest, usually due to those ventricular arrhythmias.
Okay, quite a list of potential issues to manage. So just to quickly recap them. Dilated cardiomyopathy means the heart's main pumping chambers get bigger and weaker.
Yep, that's the essence.
Causes can be varied: genes, infections, toxins, lifestyle, or sometimes just unknown idiopathic.
Correct.
This weakness leads to reduced pumping power, symptoms like breathlessness and swelling, essentially heart failure signs. Diagnosis relies heavily on echo, ECG, maybe MRI, and BNP blood tests.
Key tools, yes.
Yes, and management is multifaceted. Medications are crucial, lifestyle changes matter, and sometimes devices like ICDs or CRT or even transplantation are needed.
That covers it well.
The outlook varies, and complications like worsening heart failure, clots, arrhythmias, and sudden death are risks that need careful management. This has been a really thorough deep dive into DCM based on our source material.
Absolutely. Understanding DCM, all its different facets, and how we approach managing it is just so crucial for anyone dealing with or learning about heart conditions.
It really is. And for those of you listening who want to dive deeper into medical topics like this or find useful revision resources, definitely check out pastthemsra.com and also freemsra.com.